Good morning, everyone. I'm talking today about surgery in ROP stage 5 and stage 4. This is a case of stage 5B. I usually start my cases now with a sclerotunnel radial buckle. The aim of the radial buckle is just, and place the suture, is to decrease the circumferential area of the sclera. This improved my success rate about from 25 to 40%. Then my approach now turned from central area to the periphery. I find the space between the ciliary process and the membrane. Once I found this space, I go to directly dissect the membrane 360 degrees. It is very important to have a very good assistant, as she or he is using both her hands or his hands by indenting with one hand and using the light probe to illuminate, to identify the tissues better with the other hand. Once you successfully separate the membrane from the ciliary process 360 degrees, you will have multiple advantages. The first advantage is the retina goes back, you have more space to work, and you avoid ciliary detachment, which is a very devastating complication as iatrogenic break. And you will have the plane to dissect this membrane from the retina. Then you can use all the tools or tricks possible to dissect this membrane from the retina, whether using both by manual, using both hands to with the forceps and a scissor, forceps and a oculotome. You can use the dye to identify the membrane. The most important thing is to avoid iatrogenic breaks. Here I'm just dissecting the membrane from the retina. And at the end, I leave the case usually on air. Sometimes I inject some Helon to open just the posterior area. We get very good anatomical results in these cases. Sometimes we get a good potential, visual potential in these cases. It's not a myth to have a good potential, visual potential. This is 2 weeks post-operative on the right side, and this is 2 months on the left side of the macula on. This is another case with the same technique, also very good anatomical results. And this is the same case. This is another case also. And this is the good visual potential I'm talking about. This is a case 2 years old, post-surgery. Her father sent me this video. This is stage 4 case. I usually start with PVD in the central area. Also, it's not a myth. It's possible. You have to know when to stop. This condensation of the vitreous, this white spot, you have to stop at this point. I identify the edge of the vitreous with the membrane blue. I dissect most, if not all, of the membrane of the ridge, and I usually laser the avascular area. Clean retinal surface, very good macula, and very good results from the stage 4. Thank you.
Thank you, Dr. Ahmed. Please join us there. Dr. Suzanne. Okay. So just to make it clear for me, Dr. Janjan, you put it on you put the endothelial flap in a contact lens just to inject it, isn't it? I see. And how you was guaranteed that the surface is not upside down?
Then even if we are not doing anything without the contact lens, still it's a very private route. So we already had a mark there, and we're looking at them transferring. It's very gentle movement, so it doesn't very trifolded manner.
And when you inject the gas, is it important to be on the center of the cornea to inject the gas? So
yeah,
it's open it as an umbrella, or even at the periphery you can inject and go deep as much?
Very thin graft, so it can be fold. So it's important to be in the center or nearby, so that we don't have a cold again.
Yes.
I know nothing about cornea. So I skip my comments on cornea and go right away to the piggyback. Well, in anophthalmos, it's really a very difficult surgery in all the aspects. It's a very interesting technique. Piggyback, usually it's not easy to perform, but this kind of 2-in-1, and you can put inclavate the lens in the posterior capsule. It's very interesting. although he was not a young person, didn't you consider to make anterior vitrectomy just to make room for the lens and to not have any kind of problems from the posterior pressure on the lenses? Because it's usually the glaucoma is the problem.
Okay. This is a very good question about the technique. Anterior vitrectomy here may trigger troubles. Don't trouble the troubles until troubles are due. Because anterior vitrectomy may lower the tension in the eye, so may trigger choroidal effusion, and it happens a lot with me. Choroidal effusion is the very, very important complication in such cases. So doing ILM, doing posterior rhexis with formed globe may lower the incidence of vitreous loss. So please and try to don't trouble the anterior vitreous phase, because these patients are young and the anterior vitreous phase is stable and very condensed. So don't trouble the anterior vitreous phase. But if needed, you can do it. Barciplana anterior vitrectomy with lower manipulation, because these cases have thick sclera with vortex vein compressed. So these cases may need partial thickness sclerectomy to lower the incidence of choroidal effusion, and this is the devastating complication. So a preoperative mannitol infusion is very, very mandatory in such cases.
And you didn't have to do an iridectomy in this technique. You don't have to do it.
This technique, I didn't need any iridectomies because the EC was very deep.
Okay, thank you.
Thank you.
Thank you, Doctor, for such a nice case. Elegant technique, of course, and we all know that the small eyes or nanophthalmic or microphthalmic eyes, we have some eyes with normal posterior segment with small anterior segment or tight, and we have others that the whole eye is like small or dwarf eye, as we say. So in your case, does your technique apply to both types? The one with the tight and small anterior segment with normal posterior segment, and the other with the combo, everything is like short. Does this apply to both?
Yes. The difference between nanophthalmos is a simple microphthalmia, which the anterior segment reduced and the posterior segment reduced. But microphthalmia may be anterior reduced with normal posterior segment, and this is very good. And there may be anterior segment reduced, normal, and the posterior segment reduced, which is very dangerous because the choroidal effusion may happen.
I'm asking this question because of the one with this very small eye. Both
Yes.
We might need to do sclerotomies in order to mitigate the choroidal effusion. But if you have like normal sized posterior segment with a tight, you may not need to do such procedure.
Maybe.
Yeah. So, but it's an elegant and nice technique.
Thank you.
For the DMEC, I like the contact lens idea, to put the graft on a contact lens, and so as not to crush the flap.
Yeah, but you didn't. I thought you will inject the contact lens inside, then you pull it out. So you just
It's a very nice.
So you don't squeeze the tissue when you inject it. I think this is the idea.
Yes, this is a very, very elegant idea. But you use air, not gas.
Yeah, air.
No sulfur. sulfur.
No.
And you have to put visco. a lot,
No,
I think. No visco?
we try to avoid the visco. That's why we use anterior chamber maintainer.
No.
Yeah.
I've said on the
On the contact lens?
on the contact lens.
Yeah, a little
Because
bit.
it has to be sliding, easily,
Yeah.
glistening.
Yes, little bit of it. We just applied mixed with saline mainly, like so that it glides well on the surface.
Dr. Yusuf, you was injecting the second IOL as a single piece, isn't it?
Yes.
Single piece.
Maybe a 3-piece or single piece, but in such case it was
So
one
why
piece.
not putting the two IOL in the capsule?
Yes. Both IOL inside the capsular bag will
Have to-
cause interlenticular opacification, and this is happen, and this is the main complication. So nowadays they implant inside the capsular bag one piece, and the second IOL implanted in the sulcus called Sulcoflex. This is prepared well for biggie bag. Sulcoflex, yes. 3-piece IOL with rounded edges to not rub the iris.
What about the ICL?
The ICL, yes, this is called the secondary biggie bag. The residual error, which cannot be treated by any PRK or LASIK or refractive surgery, they do secondary biggie bag. Secondary biggie bag can be calculated easily by equation 1.5 by the residual error. So implanted in the sulcus, ICL or Sulcoflex.
And I think in the future with the 3 printed IOL, personalizing the IOL you want, you can do it. The issue is as much powerful you want, the thicknesses become difficult. So injecting it will be more even difficult. So
single piece with high
power, yeah.
But single IOL with high power cause more spherical aberration and not preferred in.
Yeah, this is true.
Yes.
Dr. Hassan Kashnawa, nice surgery to show that the removing the epiretinal fibrosis in a total retinal detachment is the core of success in those cases, actually. But he was using 23 or 25 gauge?
23.
23 gauge.
Yeah.
You go directly or you go with a tunnel? Which machine you was using?
Which Constellation.
Constellation, I
Yeah.
see. I see.
I wanna, in those cases, in a combined retinal detachment, I use a chandelier usually. Because I can't remove the membrane just using off cutter. Using off cutter, remove the membrane. There is a risk of retinal tear, risk of hemorrhage, but using of the chandelier, taking the membrane by one hand, serrated forceps, other hand is by a good scissor, you can slowly removing the membrane from the retina.
Have you did 360 or you didn't? You was not in need to do it at the end.
At the end, you need.
So you did 360.
Yeah.
I see.
Yeah, really.
And tamponade?
Tamponade silicone, because this is a combined chronic retinal detachment, single eye patient, diabetic. I am afraid from using of absorbable gas. I put on a silicone for 3 months. After that, I want to remove it.
Okay. Dr. Suzanne, please.
Well, it was a nice presentation, and there are very difficult cases. So it's very difficult to end a case without making a tear or opening retinal. So it's very, very nice cases.
Thank you.
We have a lot of them in Portugal. Somehow we have a lot of them, these cases of tractional retinal detachment, very old one with a very fragile retina, and they are very difficult to operate. And usually I do it also by manual. Most of the surgeries for retina
It's a must in those cases.
Yes, you must do it. You get to a point where you must do it by manual. So,
Dr. Youssef, just one comment. Do you have any comparison result between the biggie bag and the refractive surgery post implantation of the primary lens? Which means that?
Sorry.
No. You have a patient that the stole, because biggie bag, we are putting it for a reason. So if you need to correct over or a residual refractive error, you are putting a biggie bag. Compared to others, we can do a refractive surgery if it's possible. Do you have any comparative study or any comparative information that shows which one is the best, the refractive surgery post implantation of a primary lens or a biggie bag? And
yes,
what do you think personally?
If the patient has residual error, I will not touch the eye and do refractive surgery. It will be better than entering the eye again and put IOL with lowering of the AC depth. So this is clear for me. If the patient has any residual error, I will do refractive surgery and I will not enter the eye with all possible complication of entering the eye again.
I do agree with you.
This is clear.
Yeah, I do agree with you. Those patients that mostly have the high order abrasions that it need to be treated.
Yes.
So what we did is that we compared the result of the using piggyback and the refractive surgery, any kind of refractive surgery, definitely that's suitable or the patient is candidate for it. And we found that when we are doing the piggyback, whatever that you are preventing direct touch with the lens or you're putting in the sulcus, but still we have patients, group of patients that they have a persistent macular edema from the iris touch to the lens, especially when the surgeon, he have to put any bag and he put one single lens in the sulcus.
Yes.
And we
I agree
found,
with you.
we found that when we are doing a refractive surgery that can correct the high order abrasions, those patients, they are doing very well. More than even so, or considering that even those that we are putting the piggyback for correction of presbyopia post and putting a piggyback that can correct the presbyopia, the presbyopic laser-based treatment over on a pseudophakic is doing much better than that the piggyback.
Yes.
Thank you.
But I have cases of retinal detachment of the secondary piggyback because always the patient has iritis and uveitis, and this may trigger ciliary body traction, and this is cause peripheral tears and detachment. And I had many cases of vitrectomy for this reason. I agree with you totally.
Piggyback for those that they are not eligible for the refractive surgery.
Against, yes.
Yeah.
Do we have to do a PI, Safwan, for such cases? You might get pupillary block or something?
So you consider that the PI will solve the whole problem?
No, I mean for to mitigate for glaucoma.
We can, but the problem is not in the glaucoma. Our problem here in the fraction between the
shaving,
between
the shaving.
and because iris is a dynamic.
Yes.
We are not considering that the dynamic, what's the dynamics in. If we are having a movie that have a slow and shows how the iris passing through the lens and how it's, especially for the hydrophobic, where the edges is very sharp, and that create. And so those patients, most of them, they have a recurrent macular edema. So from this point of view, we are saying that we need to consider those when we are considering patients that we need to go through piggyback.
Yes, excellent. I guess the piggyback should concern about the negative apparition of the first IOL and the other IOL, which is positive or negative apparitions to control the apparition possible. Yes.
But you still will do the surgical iridectomy. I mean, you are already inside the eye. Why not? Why not? And the macular edema, as Dr. Safwan said, the best medication for it is the non-steroidal drops. We have a study on that, and this is work better than the anti-VEGF.
They are on a non-steroidal. I have patients for 1 year or 2 years.
True.
Once you stop it, the macular edema comes. So what we did is that we returned back to the ACV, removed the piggyback, and I kept the eye to be settled for a while of time, and then I redo the refractive. And here, SMILE can do it very well, especially if the eye or the abrasion is within. And the patient will not feel, if the patient not willing to do the LASIK or to do LASIK, because some patients, especially when they are old or not, I'm not talking about young, I'm talking about old patients.
This is not
They are not willing, not willing to do it after the LASIK.
No, the technique that the doctor showed that he is putting the second IOL, he is putting in the back.
Yeah.
Because the first IOL, he put it behind the posterior curve. So
I mean, but still there is a problem between the two lenses. When you are putting it in the back, after a while of time, those two lenses you would see in the anterior OCT, you will see that the start to be oblique, and the reactionary in between those two, there is a dot on it, there is a vast wear in the center.
and the patient is not willing to see well. So here we need to calculate or in a balance between all these factors.
Actually, it's even more precise to do the refractive surgery.
When you remove the
There's no comparison. But
So when you remove
he said it's an ophthalmos. It's a child, isn't it?
25.
Are you gonna do,
It's
are you gonna
25.
do the smile for a child? Is it?
Well, if it can be, but the refractive or laser or I'm talking in general, not talking about the precise age. I said that if the patient candidate, then we will go to the refractive better than. But if the patient not candidate, yeah, sure.
But if you Safwan, if you remove the piggyback, then will be residual hyperopia. Hyperopia. Do you do smile for hyperops?
No, I'm talking in general. I'm not talking precisely for those cases.
You talk about the adult who
Oh, there is a
deficit.
Zeiss machine has a new
I think for non-ophthalmic,
new software
maybe this
for
is the only way.
hyperopia.
Yeah.
So I will shift to Dr. Ahmed Shafei because I need to
I was waiting.
commend him for such an elegant technique, of course. And we're talking to Suzanne about very nice technique, how to dissect carefully the membrane. Be careful not to do any tears because if you do the tear, I will discussing this one. So I'll leave a comment to the mentor, his mentor.
It's a very hard time, so don't try to transform tractional detachment into erythematogenous when you cannot take completely all the membranes. So very elegant, Shafei. Thank you for the video. In the beginning, I used to go from the center to the periphery.
Yeah. This is how I used to do it.
But yes, you keep having a fibrotic ring that doesn't allow all the retina to go to its place.
Exactly, yes.
So I think the technique to come from the periphery to the center, dissecting quite well from the ciliary body, it's a very nice technique for stage 5. The only problem is that you need someone to help you. And as I don't have someone to help me, I use the hooks from the iris to really, as there is contraction, you can see the ciliary body. So I try to do it all by myself, but you need someone that really, to do this technique to help you, you need a very good
It is
person
very
with you.
important. If he or she is not there, I will not do the session.
Yes, but I must do it. So I used to pull really the iris, and sometimes sectorially. So I'm working here, I pull the hooks here just to see really the ciliary body and cut it.
The
So it's
support
very
is
nice.
important while you're pulling on the ciliary. This support is very important.
So it's very good. It's very nice if you can have a good person to help you. Then why do you put a radial? That's new for me. A radial buckle. Why not an encircle? You just put it in the temporal side. What's the rationale to put
The rationale is
the radial buckle?
yeah, it's the same idea of the scleral imbrication. You're just lowering the circumferential area of the sclera. So theoretically, if you think about it, you will need the retina to go back less, so you have better anatomical success. The thing is, this radial buckle, I actually remove it after 1 month.
But the question is, why not an encircle?
Why not?
And just a radial, because usually the detachment is complete.
Yeah,
Of course, the most detached and contracted is temporal.
well, it's this radial just solves the problem. You take the suture at the end. These two bites, you tighten it. It comes
Just
above
to
the bucket.
shorten the eye,
Yeah,
is that-
shorten the eye.
So you put it temporally, nasally?
I
You have
try
some
to
try
find
to do it?
the best place, but there is no special site. But if you have a good B scan, I usually put it on the area where the B scan is telling me that there is a fold or there is more
The
contraction
fold.
to it.
Yes,
Yes, exactly.
I understand it now.
But here the question is that why we are putting a buckle?
Yes,
That's
to
he
decrease
explains.
the circumferential area of the sclera.
Okay.
So when you do this, you have less area, where is less space that the retina needs to go back to. So you have better-
You are doing bimanual, right?
Yes, of course.
Yeah. So that was the main question for me because I was doing it in the same way. So Frank Koch is one of the famous vitreoretinal I don't know whether he's still practicing or not. So he asked me why, if you have bimanual and if you have a good elimination to do it. That's why I'm using 4-pore entry, not 3-pore entry. The fourth is to have the light in it fixed. I prepare it and I'm doing it. So just look, please, if you don't mind. So the indentation with a good shaving of the base, you don't need any external indentation. Now, I saw a few patients now done in Cleveland. The surgeon, he did a buckling with 2 or 3 surgeries. And then the buckling, definitely we stop using the buckling because it's refractive wise, it changed the refractive, and it creates a lot of inflammatory reaction to the anterior segment. So here, if you consider that you will not put a buckle, what you will do in the same case?
Now, in stage 5 cases, we're not
I'm talking about stage 5 cases.
Yes, there is no. We're not talking about refraction because there is no central vision. This is the first thing.
Yeah.
The second thing, the success rate is very low. So by putting this radial buckle, is the same idea as Dr. Subhandra said. The scleral implication, lowering the circumferential area, improve the success rate from 20. I'm doing a paper about it, from 20 to 45%, which is very huge. This is the second thing. We don't do shaving in these cases at all, because the main idea is to just remove the traction and the membranes and the attachment between the ciliary process and the ridges, and completely remove the traction and so that the retina goes back. So this is the main tackling points. And the thing is, when you have a good anatomical result, like 40%, and you have just even some visual potential in these patients, I don't need more than this.
Okay. So the case, if we will discuss the first case.
Yeah.
It was 34 patient, 34 years.
No,
the patient that I saw.
It's a stage 5. It's a stage 5 ROP. So the philosophy of the surgery in ROP is completely different.
Vitreous shaving.
We have no vitreous to shave.
Talking in general, so when we have fifth stage 5 or tractional detachment, and I have a patient that has retinal detachment. He came to me and then he decided to do the surgery after a while of time, around 2 months, when he started to have traction and